Ladies and gentlemen, thank you very much for the invitation. Huge bipolar defects. But why did it happen again? In our first study with 200 arthroscopic repairs, we have only a 9% recurrence rate, but we had seen in this group that the biggest risk factors are bone loss. It's not age, not gender, not activity level. And in the revision cases, when you looked closer to this bone defect, we could improve the results. 80% returned to sports after a mean of 9 months, 76% returned to previous level without any limitation. So the effect of bipolar bone loss is a double. On the glenoid side, of the humeral side, it's a double trouble. That is a known fact because this combination have a negative effect on the glenohumeral stability. Bipolar lesions are not uncommon. Number of bipolar defects increases with recurrence up to 8%. What image do I use? X-rays, MRIs, especially to detect additional pathologies, but also a CT scan, 3D reconstruction if possible, to evaluate the bone loss, the dysplasia, the glenoid retroversion. So the gold standard is a 3D CT scan with humeral subtraction. Most important is a correct en face view of the glenoid. MRI is more observer dependent and usually it's not possible to adjust an en face view. What do I measure? I measure on the glenoid side, I measure on the Hill-Sachs side, on the humeral side, and together the track. Why should we all measure? The history is important. Pioneering work was done by Steve Burkhardt and Joe DeBeer in 2000. They noted a high risk of redislocation with anterior glenoid bone loss, 60% failure. E.G. Itoy could biomechanically show us that 21% is a problem with a Bankert repair. Sugaya checked 100 CT scans and have seen a lot of bone loss, 50% of these cases. The easiest way is just to measure the diameter and the defect, and then you get the size of the defect. But not everything fits perfect into a box. If you do this, you will oft overestimate the defect about 5%, so that's not a good idea. The glenoid bone loss is really critical. If you have a glenoid bone loss of more than 15%, the Bankert repair cannot restore the glenohumeral translation and restricts range of motion. Why we care about the glenoid? Because of the contact area. The contact area decrease a mean of 40% and the pressure increase nearly 100%. Again, the critical bone loss is said to be around 15%. And the new philosophy by Giovanni Di Giacomo about the track on and off track concept, you can understand if we lose some on the glenoid side, the track is much smaller than the intact glenoid. But also on the Hill-Sachs side, on the humeral side, you will see more Hill-Sachs lesions in the recurrent dislocate, about 90%, but still not clear evidence for critical size. It's around 12% of the humeral head may increase in stability. So we measure now in this glenoid track concept quite easy. It's an easier way now. You measure the distance on the glenoid and you measure the distance from the rotator cuff to the anterior part of the Hill-Sachs. And if A is more than B, you have to fix it. So it's an easier, practical way for every day. In our own series with 100 patients, 88 were on track. 30% of these patients with an off-track lesion had to be revised, so it's a clear sign we have to look closer to the bipolar lesion. We have options on the glenoid side and the humeral side, arthroscopic open Bankert repair, Latarjet, J-span, allograft. On the humeral side, remplissage, posterior capsular application, iliac crest, Oates, or prosthesis. First case now, arthroscopic stabilization 4 years ago, a traumatic redislocation. We fixed it now with a Latarjet because the biggest problem was on the glenoid side. But in most cases, we address both iliac crest graft on the humeral side and on the glenoid side. Sometimes you get away just with one shot. But if it's still engaging, like in this case, you have to think about an additional procedure. It's needed to get him on track. Remplissage techniques If we have 2 knots over 2 anchors, you cover the area about 13%. If you use a double pulley system, you get about 16%. If we use now a tape bridge, we can cover about 30%. This study was done in the lab. An alternative now is a posteromedial capsular application with the new all suture anchors. This reduces the anterior shoulder instability, similar to rim remplissage without restricting motion in the setting of an engaged Hill-Sachs defect. My preferred technique to address Hill-Sachs lesions, if it's lateral remplissage, it's more medial, also Hill-Sachs or iliac crest. And if we have an epileptic history, we use a metal implant hemicap prosthesis. This is just my worst case. You see the dislocation in the humeral joint. You see the defect on the MRI, and you see the bone loss defect on the glenoid about 20%, and a huge off-track Hill-Sachs lesion. Again, CT scan now. I see a huge defect now. What are our options? That's how we treat it. We use the iliac crest bone block on the humeral side and on the glenoid side, revised it and fixed it. And this is the CT scan after the surgery, filling both defects and enlarge the glenoid. So what we have learned, a preoperative evaluation of bipolar lesions, get proper images, measure carefully, address the pathologies properly and entirely, pick the right procedure combination individually. Thank you very much for your attention.